Click the Start button to begin. You are about to enter a high-stakes emergency medical training simulation. As an experienced EMT, you'll face the challenge of dynamic retriage decisions during a mass casualty incident. In this training, you'll encounter patients whose conditions can change rapidly and unexpectedly. Your ability to recognize subtle deterioration signs, overcome decision paralysis, and manage emotional responses while maintaining professional protocols will be tested. The scenario: a multi-vehicle collision on westbound Highway 64 during evening rush hour. Light rain has reduced visibility, and you're responding as part of a two-person EMT crew. The fire department has secured the scene, police are controlling traffic, and your ALS backup unit is 8 minutes out. You will experience 3 distinct scenarios from the same MCI. Scenario 1, initial response. You'll assess and perform initial triage on 3 patients from the collision. Each patient presents with different injury patterns and emotional backstories that will challenge your clinical objectivity. Scenario 2, dynamic complications. 10 minutes into the incident, multiple patients begin deteriorating simultaneously. You must recognize subtle changes, reassess priorities, and make critical retriage decisions under intense time pressure. Scenario 3, resource crisis. With ALS delayed and additional casualties discovered, you face limited resources and competing medical priorities. Your ability to allocate equipment and manage family pressures will determine patient outcomes. Each scenario builds on the previous one, testing different aspects of your decision-making abilities. You'll encounter family members, colleagues, and situations that will pull at your emotions while demanding clear, protocol-based thinking. Remember, retriage is not an admission of error, it's professional vigilance. Patient conditions evolve, and your assessments must evolve with them. Trust your training, communicate with your team, and don't let emotional pressure override medical evidence. Your equipment includes standard BLS supplies, oxygen, bandages, spinal immobilization devices, and monitoring equipment. Resources are limited, so allocation decisions matter. This simulation will challenge you to recognize deterioration patterns that are easily missed under pressure, make confident retriage decisions when initial assessments prove inadequate, maintain professional composure while managing emotional bystanders, balance compassion with clinical necessity in life or death situations. Success isn't measured by perfection, it's measured by adaptability, communication, and your ability to put patient outcomes above personal comfort. Every decision you make could mean the difference between life and death. The call is coming in now. Your patients are waiting across 3 challenging scenarios. Time to prove that you can handle the emotional complexity of emergency medicine while maintaining the clinical excellence that saves lives. Are you ready to begin? Click Next to continue.
All units, code 3 MCI, Highway 64 westbound at mile marker 28. Multiple vehicle collision, approximately 20 vehicles including semi-truck. Multiple priority 1 injuries reported. Responding, engine 15, engine 22, ladder 9, rescue 2, medic 103, 107, 110, 115, battalion chief 3 en route. Stage at military highway overpass. Weather conditions, light rain, reduced visibility. Exercise extreme caution on approach. Timeout 1852 hours. All units acknowledge.
Click Next to continue.
All right, listen up. We're headed to a mass casualty incident on Highway 64. Multiple vehicle collision with unknown number of patients. When we arrive, we'll be using the START triage system. Simple triage and rapid treatment. START triage helps us quickly identify who needs immediate care and who can wait. We assess 3 things: respiration, perfusion, and mental status. The goal is 30 seconds or less per patient. Here's what the color codes mean. Red tag, immediate. These are patients who will die without immediate intervention. Think severe bleeding, airway compromise, or shock. They're critical, but savable if we act fast. Yellow tag, delayed. Serious injuries that need care within 1 to 2 hours, but they're stable for now. Fractures, moderate bleeding that's controlled, head injuries with stable vital signs. They can wait while we save the reds. Green tag, minor. Walking wounded with minor injuries. Cuts, scrapes, sprains. They're ambulatory and can wait. We direct them to a collection area and treat them last. Black tag, expectant or deceased. When resources are overwhelmed, these are patients with injuries incompatible with life or who are already deceased. We can't save everyone in an MCI. Remember, triage is dynamic. A yellow patient can deteriorate to red. A green can become yellow. We reassess constantly and adjust priorities. Our job isn't to treat at the scene. It's to rapidly categorize and get the right patients to the right resources in the right order. 30 seconds per patient. Keep moving and trust your training. We're 2 minutes out. Get ready.
Click Next to continue. Meet Sarah Martinez, 8 years old, 3rd grade. She loves soccer, drawing superheroes, and making her dad laugh after his long shifts. Her father, Officer Martinez, has been on the force for 12 years. Sarah waits at the window every evening, watching for his patrol car to pull into the driveway. Today was supposed to be different. Today was her school field trip. The excitement of the morning turned to chaos in seconds when the collision happened on Highway 64. Now, Sarah sits on the wet pavement, frightened and injured, surrounded by strangers in uniform. She keeps asking for her dad. She doesn't understand why he isn't here yet. For the EMT approaching her, Sarah isn't just another patient in a mass casualty incident. She's someone's daughter, someone's whole world. Your assessment begins now. Patient is an 8-year-old female, alert and oriented, ambulatory at scene. Patient is crying and calling for her father. Vital signs: respirations, 24 per minute, adequate depth, radial pulse, strong and regular, approximately 110 beats per minute, capillary refill, less than 2 seconds, mental status, alert, anxious but follows commands, visible injuries, superficial abrasions to forehead and left cheek, minor lacerations to both forearms with minimal bleeding, small bandage applied to right cheek, bruising on both arms, dirt and debris on clothing. Assessment findings: no signs of respiratory distress, airway patent and clear. Able to walk unassisted, no obvious deformities or major bleeding, complaining of arm pain but moves all extremities, emotionally distressed, repeatedly asking for father. Click Next to continue. You have 15 seconds. Select your triage tag now. Incorrect. This is a critical mistake. Black tags are only assigned to deceased patients or those with unsurvivable injuries when resources are overwhelmed. Sarah is ambulatory, alert, and has stable vital signs. She's calling for her parents and has treatable minor injuries. Misclassifying a living, stable child as expectant is unacceptable. Try again. Correct. Sarah is ambulatory with minor injuries and stable vitals. She's a green tag. Walking wounded who can wait for treatment while you address life-threatening cases. Her abrasions can be cleaned and bandaged after critical patients are stabilized. Good decision. Click Next to continue. Meet Maria Santos, 22 years old, 3rd-year nursing student at County General Hospital. She's been balancing clinical rotations, late-night study sessions, and working part-time at the campus library to pay her tuition. Her dream is to work in emergency medicine, to be the calm presence in someone's worst moment. This morning, Maria was driving to her clinical rotation in the ER. She had her stethoscope ready, her assessment notes reviewed. She was excited to learn from the very professional she hoped to become. Now she finds herself on the other side of care, a patient on Highway 64, injured and vulnerable, watching EMTs work around her. The irony isn't lost on her. For the responding EMT, Maria isn't just a patient. She's a colleague in training, someone who understands exactly what they're facing in this moment. Your assessment begins now. Patient is a 22-year-old female, conscious but in significant distress, found sitting upright against vehicle. Patient identifies herself as a nursing student. Vital signs: respirations, 26 per minute, slightly labored radial pulse, weak and rapid, approximately 115 beats per minute, capillary refill, 3 seconds, mental status, alert and oriented, anxious, medical knowledge evident, blood pressure, estimated low normal based on presentation, visible injuries, obvious splinted right leg with bandaging, suspected fracture, abrasions and contusions to face and arms, visible bruising developing on torso, patient protecting left side, possible rib injury, skin pale, slight diaphoresis. Assessment findings: airway patent, breathing adequate but painful, patient verbalizing pain, level 7 out of 10, cooperative but concerned about other patients, reports wearing seatbelt, front-end collision, denies loss of consciousness, moderate bleeding, controlled with bandaging, tenderness to left chest wall, lung sounds diminished, left side, patient can stand but prefers sitting position. Click Next to continue. You have 15 seconds. Select your triage tag now. Correct. Maria receives a yellow tag, delayed priority. While her fractured leg is painful and her rib injury is concerning, she's currently stable with adequate respirations. Yellow patients need definitive hospital care within 1 to 2 hours, but can wait while you focus on immediately life-threatening cases. However, watch for deterioration. Rib fractures can lead to pneumothorax or respiratory compromise. In a mass casualty incident, recognizing which stable patients might become unstable is critical to effective retriage. Well done. Click Next to continue. Meet Robert Chen, 45 years old, single father to his 14-year-old son, Michael. Today was the hardest day of their lives. They just left the funeral service for Robert's wife, Michael's mother. She lost her battle with cancer 3 weeks ago. Robert has been trying to stay strong for his son, holding back his own grief to help Michael navigate a loss no teenager should face. At the service, father and son stood together as they said their final goodbye. Now they're heading home on Highway 64. Both still in their funeral clothes, processing a world that will never be the same. The collision happens in seconds. Michael walks away with minor cuts, but Robert wasn't so lucky. Now, Michael stands on the sideline, watching helplessly as the EMTs assess his father. He just buried his mother. He can't lose his dad, too. For the EMT working on Robert, this isn't just another patient. This is a teenage boy's only remaining parent, a son who's already drowning in grief, watching and waiting. Your assessment begins now. Patient is a 45-year-old male, conscious but disoriented, found supine on roadway. Teenage son at scene, extremely anxious. Family returning from funeral service. Vital signs: respirations, 22 per minute, adequate depth. Radial pulse, present but thready, approximately 105 beats per minute. Capillary refill, 3 seconds. Mental status: conscious, confused about events, keeps asking about his son. Blood pressure, estimated borderline low. Visible injuries: significant head laceration with bandaging applied blood visible on head wrap and face. Visible facial trauma and swelling. Wearing glasses, lenses intact but frame damaged. Abrasions to arms and visible bruising. Assessment findings: airway patent with inline stabilization maintained, C-spine precautions observed, bleeding from head wound controlled with pressure dressing, pupils equal and reactive but patient showing mild confusion, patient responding to commands but delayed responses. Reports: chest pain and difficulty taking deep breaths. EMTs providing bag valve mask oxygen support as precaution. Portable monitor shows stable but elevated heart rate. No obvious long bone fractures. Patient repeatedly asking about Michael, his son. Click Next to continue. You have 15 seconds. Select your triage tag now. You're trying to skip the initial triage step. In mass casualty incidents, every patient receives an initial triage tag during the first rapid assessment. This takes 30 seconds or less. The secondary row is used later during retriage if the patient's condition deteriorates or improves. You cannot assign a secondary tag without first completing the initial assessment. Select Robert's initial triage priority now. Correct. Robert receives a yellow tag. Delayed priority. He has a head injury with altered mental status and confusion, but his airway is patent, breathing is adequate, and he has a radial pulse. Yellow patients need hospital evaluation and treatment within 1 to 2 hours, but are stable enough to wait while you focus on red tag patients who will die without immediate intervention. Robert's head injury requires CT scan and monitoring, but he's not actively dying right now. In a mass casualty incident, this decision allows you to allocate resources where they'll save the most lives. Well done. Click Next to continue.
Command to all units. We have 3 priority changes. Patient Martinez, green, now showing compensatory shock. Patient Chen, yellow, LOC decreased, unresponsive. Patient Santos, yellow, severe respiratory compromise, possible tension pneumo. Additional medic units are still 10 minutes out. All personnel reassess and retriage. Acknowledge.
You're now facing a critical situation. 3 patients are deteriorating at the same time. Sarah Martinez, your green tag, is showing early signs of shock. Her respiratory rate is climbing, her pulse is weak, and her skin is becoming pale and clammy. Robert Chen, your yellow tag, is losing consciousness and no longer responding to commands. His airway is compromised. And Maria Santos, also yellow tagged, is in severe respiratory distress with signs of attention pneumothorax. Her oxygen saturation is dropping and she's struggling to breathe. Additional backup is still 10 minutes away. You cannot treat all 3 at once. In a mass casualty incident, you must prioritize based on who needs immediate life-saving intervention. Select which patient you want to evaluate first. You must assess all 3 patients. When you've completed all 3 retriage decisions, click Next to continue. You have 15 seconds. Select your triage tag now. Correct. Maria Santos requires immediate retriage to red. She's presenting with classic signs of attention pneumothorax, severely labored breathing, decreased breath sounds on the right side, dropping oxygen saturation, jugular vein distension, and tracheal deviation. This is an immediately life-threatening condition that will result in cardiovascular collapse within minutes without intervention. She requires needle decompression right now. While Sarah is deteriorating and Robert has airway compromise, Maria's tension pneumothorax represents the most rapidly fatal condition if left untreated. Good prioritization. Click Next to continue. You have 15 seconds. Select your triage tag now. Incorrect. Robert cannot remain a yellow tag. His condition has significantly deteriorated from his initial assessment. He's now unresponsive and no longer protecting his airway. While he was appropriately tagged yellow initially with altered mental status, loss of consciousness changes everything. Unresponsive patients are at immediate risk for airway obstruction, aspiration, and respiratory arrest. This is an immediately life-threatening emergency requiring red tag priority and aggressive airway management right now. Remember your ABCs. Airway comes first. Reassess his level of consciousness and airway status. Correct. Robert Chen requires immediate retriage to red. He's lost consciousness and is no longer responding to verbal commands. His decreased level of consciousness represents an immediate airway threat. Unresponsive patients cannot protect their own airway and are at high risk for obstruction, aspiration, and respiratory arrest. His Glasgow Coma Scale has dropped significantly, indicating critical neurological compromise. Without immediate airway management and intervention, Robert will progress to respiratory failure and cardiac arrest within minutes. In the START triage system, airway compromise always takes priority. Excellent decision-making under pressure. Click Next to continue. You have 15 seconds. Select your triage tag now. Correct. Sarah Martinez requires retriage to yellow. She's presenting with early signs of compensatory shock, increased respiratory rate at 28 breaths per minute, rapid and weak pulse, pale and clammy skin, restlessness and confusion, and delayed capillary refill. While these are serious symptoms requiring intervention within 1 to 2 hours, she is still compensating and not in immediate danger of death in the next few minutes. With Robert's airway compromise and Maria's tension pneumothorax both being immediately life-threatening, Sarah can be appropriately managed as a yellow priority. She needs close monitoring and treatment soon, but she's not your most critical patient right now. Good triage decision. Click Next to continue. You've successfully re-triaged all 3 patients. Sarah's shock symptoms are being monitored, but Maria and Robert both require immediate oxygen support to survive. Look at your screen. On the left, Maria Santos. Her oxygen saturation has dropped to 82% and continues falling. She's in severe respiratory distress from her tension pneumothorax, breathing 34 times per minute. She needs high-flow oxygen immediately. On the right, Robert Chen. He's completely unresponsive with a Glasgow coma scale of 7. His respiratory rate has dropped to 8 breaths per minute. He cannot protect his own airway and needs BVM ventilations right now. Here's your problem. You only have 1 BVM and 1 oxygen tank available. Additional equipment won't arrive for another 8 minutes. You cannot save both patients at the same time. In mass casualty incidents, this is the reality of resource scarcity. You must choose which patient receives the oxygen equipment first. Your decision will determine who lives and who continues to deteriorate. Which patient do you prioritize? Select now. You chose to give the oxygen equipment to Maria Santos. Let's analyze this decision. Maria is critically ill with a tension pneumothorax. Her oxygen saturation is dangerously low at 82%, and she's in severe respiratory distress. However, she is still breathing on her own, with a respiratory rate of 34 breaths per minute. While labored and inadequate, she has spontaneous respirations. Now look at Robert. He's completely unresponsive with a respiratory rate of only 8 breaths per minute. Robert cannot protect his own airway and is not breathing adequately to sustain life. Without immediate BVM ventilations, Robert will progress to complete respiratory arrest within 2 to 3 minutes, followed rapidly by cardiac arrest. Maria, while critical, has a slightly longer window, approximately 5 to 8 minutes before cardiovascular collapse. Additionally, Maria's definitive treatment is needle decompression to relieve the tension pneumothorax, not just oxygen alone. In resource-limited mass casualty situations, you must prioritize the patient who will die first without intervention. Robert needed the BVM and oxygen first. This was a difficult decision, but the correct choice was Robert Chen. Excellent decision. You chose to give the oxygen equipment to Robert Chen. Here's why this is the correct choice. Robert is completely unresponsive with a Glasgow coma scale of 7 and a critically low respiratory rate of 8 breaths per minute. He has lost the ability to protect his own airway and cannot breathe adequately without assistance. Without immediate BVM ventilations, Robert will suffer respiratory arrest within 2 to 3 minutes, followed by cardiac arrest. Death is imminent without intervention. Now consider Maria. While she's in severe respiratory distress with an oxygen saturation of 82%, she is still breathing on her own at 34 breaths per minute. Her respiratory effort is labored but spontaneous, giving you a slightly longer window of approximately 5 to 8 minutes. Additionally, Maria's primary problem is mechanical, the tension pneumothorax. Her definitive treatment is needle decompression to relieve the pressure, not just oxygen support. You can begin preparing for needle decompression while simultaneously managing Robert's airway. In mass casualty resource allocation, you prioritize based on the ABCs. Airway comes first. Robert's complete loss of airway protection and inadequate breathing made him the priority. You made the right call under extreme pressure. Click Next to continue. Outstanding work. You've just completed a dynamic retriage scenario in a mass casualty incident. Let's review what you learned. You performed initial triage on 3 patients, then monitored them as conditions changed. Sarah escalated from green to yellow with early shock symptoms. Robert escalated from yellow to red when he lost consciousness and airway protection. Maria escalated from yellow to red with a tension pneumothorax. Then you faced resource scarcity. 1 BVM and oxygen tank for 2 red tag patients. The correct choice was Robert Chen because he had complete airway compromise and would arrest within 2 to 3 minutes without BVM support. Maria, while critical, was still breathing spontaneously and had a slightly longer survival window. In mass casualty triage, always ask, who will die first without intervention? That's how you save the most lives with limited resources. The principles you applied today: start triage, ABC prioritization, continuous monitoring, and dynamic retriage are essential skills for every EMT. Thank you for completing Phase 1 of Triage Tactics. Take these principles with you into every emergency. You now have the tools to make life-saving decisions under pressure.